That's meaning 1 in 4 will have a poor reproductive prognosis. Unfortunately, the clinical management with poor ovarian response is frustrating, and it's almost a daily practice challenge. Thank you, Professor Hisham. He told us about the follicular wave theory, about the 2 cycles, 2 wave cycles and the 3 wave cycles. Almost 68% of the women will have the 2 cycles, the 2 wave cycle follicular genesis, and the 3 about 30%. Regarding the follicular wave, we have a twist in the stimulation protocols. We may use the double ovarian stimulation, which would be an effective way to yield a high number of oocytes in a shorter period of time, means follicular and luteal stimulation. And it has been confirmed that follicular and luteal waves yields similar number of euploid blastocysts. It has its own base and ground in oncofertility protocols, and it shows a glimpse of hope in management of poor responders. Second, progestins now can be used to prevent LH surge. First, medroxyprogesterone acetate was used, and now we may use digoxin or utrogestane. And because of the dollar problems and everything, digoxin is used a lot in the everyday practice nowadays. Our study aimed to compare between the progestin prime double stimulation protocol against 2 cycles of flexible antagonist protocol regarding fertilization rate, implantation rate, clinical pregnancy, and ongoing pregnancy rate, and to compare between the follicular and luteal phases regarding the total days of stimulation, retrieved oocyte number, fertilization rate, and resultant embryo number. And we have the honor to present it as an oral talk in ESHRE in Milano 2022. This study was a randomized control study that was held in Shelby, Alexandria. We had 90 patients. Our inclusion criteria with the Bologna criteria, and exclusion criteria includes factor infertility, uncorrected uterine pathology, severe endometriosis, or high BMI. The patients were grouped in 2 groups, each 45. In the progestin prime double stimulation protocol, digoxin was used from 2nd day of menses all through the stimulations. Gonadotropins was used 2nd day of menses. They range from 225 to 375 international units per day, trigger with agonist. Then the 2nd day of the pickup, we use the luteal phase stimulation, and again triggered by agonist, and of course freeze all and embryo transfer in a subsequent cycle. And the flexible goes in 2 cycles. First were triggered by GnH agonist, and second by HCG, because we have a mix of fresh and frozen embryo transfer. This is our consort. We started with 100 patients, we randomized 90, and we have ended 41 in a group and 42 in another group. Results showed the demographic data and hormonal profile, no statistical significance. And when we compare the progestin prime double stimulation and the flexible antagonist in 2 cycles, we have no difference in the total days of stimulation or the dosage. But in the dual stimulation, we had significant more oocytes retrieved, yet there was a trend for higher M2 and embryos, but didn't show any statistical significance. Fertilization rate were both in the same with no statistical significance, and embryo and pregnancy rates, implantation rate, and clinical ongoing pregnancy rates showed no difference. And when we compare the 2 phases of the follicular and luteal stimulation, we had more M2, more embryos, and we care about more embryos, and the M2 were higher from the luteal phase than the follicular. And of course, the total dosage used and the days of stimulation were higher in the luteal phase in comparison with the follicular one. And the fertilization rate was higher. Regarding our literature review, now we have almost 2 studies comparing the dual stimulation protocol against 2 antagonist protocols. The BESTM study was just released in August, I think, 2023. They were comparing dual stimulation just with antagonist, using in the follicular antagonist, luteal used nothing as pituitary suppression against two flexible antagonists. They showed that the M2 numbers and total embryos showed no statistical significance, only embryo transferring were higher in the control group than the double stimulation, I think due to that the patient may in one cycle have an embryos that can be transferred. There's no rule for going for luteal, another stimulation and FET, and to be frozen and then transfer. So they had a clinical pregnancy rate higher in the control than the double stimulation group. And in another study, only released in March 2023, they were comparing double stimulation against 2 cycles. Problem with the laptop? Yes. They showed that there were no difference between the days of stimulation, gonadotropins, M2 numbers, and euploid embryos obtained. But before these studies, there was only comparing the dual stimulation with only 1 wave cycle, as if you are comparing 2 cycles of stimulation against 1. So for sure, the dual stimulation was better. They had in Sifani-Nodis and Ital in the systemic review showed that I have higher resultant embryo numbers, and Glovsky Ital, I also have a higher number of embryos, but I'm comparing 2 waves of stimulation against 1. And also when they compare between the follicular and the luteal phase, they show that I have in the luteal phase more oocytes being retrieved and the resultant embryos being more from the luteal than the follicular. But now the safety and the euploid rate is very, very important for me. Am I compromising my patient? Am I compromising my oocyte or no? So I want to have to know what the progestin do and may it harm or not. In these studies, they showed that there's no statistically significant in the resultant embryo number. Yet, in Choi et al., the last one, in their meta-analysis, they have even the progestin primed have a higher resultant embryo numbers. There are now studies that they are showing that the progestin may affect the euploid rate, may not, still a debate that must be governed. Our take-home messages: poor ovarian responders will be always a great challenge to the fertility expert. Progestin prime double stimulation may be used and can be used in poor ovarian responders. Digoxin use is an effective way of pituitary suppression, and nowadays we use it a lot because of the high cost of the antagonist and the rarity of the agonist. Further studies may need to compare the euploidy between the phases of the progestin prime double stimulation, and obstetric outcomes for sure must be studied. Second, I must thank my professors, colleagues, and my mentors, Professor Dr. Shif Ghaffar and Dr. Ashraf Hani Abdurrahman, and thank you for my beloved city, Alexandria. Thank you.
And you thank you because you saved for us 5 minutes for discussion. Thank you very much. Now it is the time for questions. Speaker number 1, Professor Hisham Arab. His topic was new trends in follicular recruitment. حد من anyone؟ اتفضل short يا شريف.
The outcome. How many studies and what is the quality of this evidence?
Great. Well, thank you for doubting this study. Actually, I put it deliberately to show you that this is something unbelievable. All right. For any antioxidants to work, you have to really to look at the reactive oxygen species that's coming out from the mitochondria, which is really something that will take some time to cause the apoptosis and to cause the bad effect on the follicles. And for that correction, you need 3 to 6 months in order to see a difference. I mean, I didn't put some of that to follow, but to show you that there are some bad, actually, studies that in the out, they might really use this kind of concept, but the original study used it for 6 months, and that has shown an effect. And it has been shown not on that study, there is also other studies that have shown the effect of 6 months management before. For me, or my IVF cycles now, I put my patient 3 to 6 months before on antioxidant, and then I bring her for stimulation.